Welcome to this narrated PowerPoint presentation that summarizes some of the main points or the highlights from Chapter 4 in Loosening Grip on alcohol use disorders. As we get ready to begin this chapter, recognize two things that, as has been said previously, this PowerPoint presentation is not intended to substitute for your reading of the chapter, so please, in addition to listening to that and viewing the presentation, make sure that you read the chapter together, all the information that's contained in there. And then number two, recognize that we're now at the point in terms of looking at this topic that we're moving from an understanding of substances and the impact of substances on the body and on the brain and onto the various systems of the body, with now beginning to say, so if there are these problems that are associated with the chronic use of alcohol and other substances, what is it that determines or defines or allows us to clinically diagnose the presence of or the existence of an alcohol use disorder? So we're now moving from understanding the substances to looking at, quote, alcohol-related problems, alcohol use disorders, and substance-related disorders. Very quickly, the chapter is kind of going to cover these four primary points. It does start by taking a look at some of the early and then evolving to the current definitions or understanding of alcohol use disorders. We will also take a look at the disease concept. You want to be familiar with this term for a couple of reasons. Early on, there was some research that was done by a statistician, a biostatistician, and a researcher, which ultimately was considered seminal work for understanding the progressive nature of alcohol-related problems. That work was originally done by E.M. Jellinek, who again was a researcher. His work was then followed up on by an individual, George Valiant, who really extended his work and really looked to kind of either verify what he found or to update his findings. So you're going to really want to be familiar with the original work of Jellinek and the Jellinek chart and the progression, and then the follow-up work done by George Valiant. So we'll look at the disease concept and the progression, and we'll look at the natural history of alcohol use disorders. And then we'll close with taking a look at how or what symptoms are used to, quote, diagnose the presence of alcohol use disorders. You're going to see and hear about the evolution from some of the early diagnostic criteria, signs, and symptoms to how we understand it today. If you're going to work in a substance use disorder treatment facility, then you will need to be familiar with the DSM-5 criteria. We're going to talk more about it. You'll be exposed to that not just now, but during the remainder of the course. I would highlight in particular at the top of page 102 in your book, there is a list of the 11 criteria that are used to diagnose the presence of an alcohol use disorder. And so be familiar with those and the concept of diagnosing using the DSM-5. As you'll see in the chapter, there were we've always tried to, quote, understand or identify what is it that is present that, quote, defines the existence or the presence of this problem. And they talk about some early understandings of it, i.e. a focus on it being a moral weakness or a moral inferiority, a spiritual weakness or a spiritual inferiority, and ultimately evolving to the point, our understanding has evolved to the point that over time there began to be more recognition that it was not a spiritual or a moral or another form of weakness, that it really was a separate problem or separate condition that was ultimately conceived of as a medical condition, an illness, a health concern that required medical treatment versus any other kind of intervention. And so earlier definitions, this discussion is held on the first couple of pages of the chapter on pages 85, 86, 87. Early definitions focused on the origins of the condition, and ultimately they focused on the problems or the, quote, the unfortunate consequences that were associated with alcohol use, and began to cluster on or highlight the more predominant or hallmark signs or symptoms of the alcohol or alcohol-related problems. They also proceed to talk in that chapter about as it began to be better and more understood and actually more widely researched and recognized, there began to emerge the beginnings of some shared or uniformity in the terminology in terms of how we're going to classify or talk about this. And they talk about how early on the World Health Organization began to introduce terms. Also, at the similar time, the American Psychiatric Association, the APA, also began to clarify and use the same terms to begin to promote or create a greater and a shared understanding of what alcohol use disorder is, although at the time it was alcohol dependence. The World Health Organization ultimately has a system called the International Classification of Diseases, or the ICD system, currently ICD-10. The American Psychiatric Association also published their manual known as the Diagnostic and Statistical Manual, currently on the 5th edition, so DSM-5. And so there are similarities, some coding differences that exist between how the World Health Organization and how the American Psychiatric Association has classified alcohol use disorders, other substance-related disorders, etc. Over time, part of what happened is that we moved away from the term alcoholism or alcoholic to a medical term, alcohol dependence syndrome. We ultimately also evolved from looking at as, quote, addiction to looking at as dependence. And those terms are discussed in the chapter. So be familiar with the difference between addiction and dependence, between alcoholism and alcohol dependence syndrome, as it's laid out in the chapter. Today, what you're going to hear when we get to the DSM-5 criteria is that we now use the term substance use disorder, but we specify which substance we're talking about. So somebody with an alcohol problem is going to be diagnosed with an alcohol use disorder. Somebody with a cocaine problem will be diagnosed with a cocaine use disorder. So with the publication of the DSM-5 criteria, we no longer talk clinically about substance abuse, substance dependence. We now talk about alcohol use disorders, and we characterize those on a scale of either mild, moderate, or severe. We'll talk more about that both in this and in subsequent chapters. A companion or a specialty organization, not a companion organization, but a specialty organization here in the United States, the American Society of Addiction Medicine, or ASAM, ultimately, which specializes in addiction medicine, obviously, ultimately promoted or promulgated the idea that we needed to look at alcoholism or alcohol use disorder as the following things. It's a primary chronic disease. This, by the way, is on page 89 of the text, but it's a primary chronic disease. Primary means it is the area of focus. It's not considered secondary or tertiary or not a primary condition. Chronic versus acute. So chronic means if a person has an alcohol use disorder, he or she will have that condition on a long-term chronic, not going away basis, recognizing that it has a complicated origins. There are genetic components to it, there's psychological components to it, there's environmental components to it. There's a discussion in the chapter about the difference between, or reference to a heterogeneous condition, so a variety of things account for the development of alcohol and other substance use disorders, and also the recognition that if it is left untreated, number one, it's going to get worse, so it's progressive. It gets worse over time. And also, ultimately, if it's untreated, it's going to be fatal. They also talk in the middle of page 89, as part of the ASAM definition, that it's characterized by continuous and periodic impaired control over drinking. It's a chronic relapsing illness, and so people go into periods of abstinence and then they return to use. And so there's remittent relapse. There is characterized by preoccupation with their continued use of drugs and or alcohol, and people continue to use despite knowing that it's causing them problems. It changes people's thinking. All those are aspects of alcohol use disorder that end up being captured in the diagnostic criteria. And actually, I made reference to these a little bit earlier. So these are the characteristics of the illness. I've talked with you about all these already, so I'm not going to repeat them here. I said them on the previous slide. They also talk in the chapter about the significance of looking at alcohol use disorder and substance use disorders as illnesses or disease, as opposed to moral weakness, spiritual weaknesses, poor choices, crimes, etc. by classifying it and by recognizing it and understanding it as a disease, what it did is it now says we don't need to lock people up. We don't need to pray for people necessarily. What we need to do is look at what we can do to, quote, provide treatment services. And so from a implication perspective about looking at this disease, and now means that treatment is what we need to provide versus any other response. It also said that it wasn't in the domain of the criminal justice system. It now falls into the domain of the healthcare system. And so healthcare resources needed to be provided for people as opposed to other kinds of interventions. It also meant that people were no longer being labeled ideally as criminal, etc. And so it reduced the stigma that's associated with the condition. If there is no stigma associated, for example, with having other chronic health conditions such as diabetes, then by looking and understanding it as a disease, it ideally will reduce the stigma that's associated with alcohol use disorder or other substance use disorders. And also served as a motivation for the federal government in particular, but ultimately state governments as well, to identify if it is in fact a medical condition, then what do we need to know to understand these problems? And based upon that understanding, what is it we will do to be able to effectively treat and also to potentially prevent the emergence of these problems? And it is critical that you recognize the role of the federal government. Much of the research being done today and much of the information that clinicians can access is coming through the federal healthcare system. You would want to be familiar with an organization like SAMHSA, Substance Abuse and Mental Health Services Administration, SAMHSA.gov, National Institute on Drug Abuse, National Institute on Alcoholism and Alcohol Abuse. There's a variety of federal agencies, Center for Substance Abuse Treatment, Center for Substance Abuse Prevention, that play key roles in researching, understanding, and disseminating research in a way to help us understand and effectively treat and prevent the emergence of these problems. It's important to recognize, too, that there is not necessarily uniform agreement or endorsement of alcoholism or substance use disorders as diseases. And in particular, there are some folks who would argue, as noted here, that there are folks who consider alcohol use disorders as symptoms of other conditions, i.e., if people are primarily depressed and using alcohol, then the alcohol use disorder is a symptom of their depression. And so there are individuals who would say that the substance use disorder is symptomatic of other conditions, and therefore we need to treat the other conditions, and the alcohol or substance use disorder will resolve itself. There also are people who would argue that people who are using substances basically lack the willpower, they don't have the strength to say no, or they're rebels, I guess that's the word. They don't pay attention to or adhere to society's rules and expectations, which really are folks who still fall back on kind of a weakness perspective on the presence of this particular condition. And there's also been some criticisms about the fact that by identifying it and recognizing it as a disease, does that mean we're excusing people for the behavior that they exhibit as a result of their disease? One of the things that you'll become familiar with is that when people are actively in their addiction, many times they will do things that they wouldn't normally do had they not been wrestling with their addiction. And so, and that includes things that are illegal, things that may put them or partners at risk, etc. So it's important to recognize that for folks who are critical of the disease concept, what they would perceive is that by viewing it as a disease, we're giving people, we're holding people not accountable, allowing people not to be accountable for their decisions. And so these criticisms of the disease are really defined or described on pages 91 and 92. Be familiar with that. Full disclosure is that the longer I work in the field, the more I take a look at research, etc., I really firmly believe that substance use disorders, alcohol use disorders, substance use disorders, are in fact a function, what's called the brain disease. I think ultimately, as we look at reward systems, as we look at how mood-altering substances impact our brain, what happens as people develop a substance use disorder is the repeated use of the substance alters our brain, alters the response of our brain. There's things that trigger that, there's things that predispose us to that, but ultimately what happens is repeated use changes the way our brain operates, and therefore we're wrestling with a lifelong condition that has been caused by our repeated use of the substance. So I do firmly believe that substance use disorders, including alcohol, etc., are in fact diseases, and in particular are best understood as primarily brain diseases. By looking at alcoholism as a chronic disease, and as you see here, if it is in fact a chronic disease, and I don't think that's the question. So, given that alcoholism is a chronic disease, then the elements involved in learning to live with and learning to manage this disease are the same as the elements that are important to any other chronic disease. And so we have to learn how to treat the acute flare-ups. When people relapse, it's an acute flare-up. What do we do when there's an acute flare-up? We have to provide our clients with emotional support. We have to help people learn to live with and understand their condition. So we have to educate clients or patients to substance use disorders. We have to help them learn how to live, but to live a lifestyle that supports their recovery. So living with limitations. If you have a substance use disorder, then this understanding of it would say that therefore what you're going to need to do is learn to live without using alcohol, for example. So people have to learn to live, but with certain limits in place to manage their disease. Ideally, it's going to involve family and a supportive role. If you're learning to live with diabetes, then you want your family members to be aware of what you have and how to help you stay healthy, remain healthy, etc. So family involvement is critical. And it's also viewed as a partnership. In many conditions, it's a partnership between the physician and the patient. In this case, oftentimes in substance use disorder treatment settings, there is less physician involvement, oftentimes more involvement with clinicians, etc. But ultimately, it still is similar to the relationship develops or the partnership develops between a physician and a patient. So the same things that we do to treat other chronic conditions, i.e. diabetes and heart disease and other chronic health conditions, HIV infection, are the same things that we have to do when we're helping people learn to live with or learn how to manage their alcohol use disorder. As I introduce the chapter and on page 92 of the text, they then start to talk about two important historical approaches to understanding alcoholism. As I said earlier, so E.M. Jellinek was a trained statistical researcher, a biostatistician, who really looked at data as a way to try to, quote, make sense of what happens as people become, quote, alcoholic. And in the course of gathering information, and it's described in a lot of detail on pages 92, 93, and 94, 95, you're going to see all this summarized there, or all this included there. So the summary is that ultimately from looking, gathering, collecting, and analyzing data, Jellinek ultimately suggested that, or conceptualized that alcoholism could be understood as emerging or occurring in four predictable phases, that people would go from phase 1 to phase 2 to phase 3 to phase 4. And so the first two phases are shown here. For people who are pre-alcoholic, it's characterized by what you see there. At this point, the use of alcohol is motivated by social factors, social motivation, fitting in, being comfortable, things like that. There is not yet tolerance, which, as you know from previous exposure, tolerance means the body has developed, has adapted to the presence of a substance. In the pre-alcoholic phase, there is not that adaptation, and so tolerance begins to develop gradually. And in his study, which was primarily adult males, this phase would be roughly a couple of months in length to, for some people, a couple or more years in length. So a very variable length at which a person would go through this phase, a change from person to person. Jellinek then said that the next stage for people who are going to progress to developing alcoholism would be the continuation of what he called the prodromal phase, which in particular, and you'll see this in the chapter, for Jellinek, it was his finding that people who enter the prodromal phase always experience what are called alcoholic palimpsest, more commonly known as blackouts. Later on, we're going to talk about the fact that blackouts are not universal, and so some of his earlier thinking did not hold to be true. But this was his perception of the phases of alcoholism, is that when people began to experience blackouts or palimpsest, that now meant they had entered into this second or prodromal phase. The person is drinking more than previous, so their consumption is heavy, but there aren't necessarily observable signs or symptoms, so it's not always conspicuous. And at this point, he says that this phase could last anywhere from 6 months on up to 4 or 5 years. And then the final two phases, per Jellinek, were which are what he called the crucial phase, which is characterized at this point. We see the individual losing control of his alcohol consumption. Again, Jellinek's study was primarily on adult male alcoholics, adult male European alcoholics, ironically. And so at this point, characterized by loss of control. And he made a distinction that the person may be able to control whether or not they take the first drink, but once they take the first drink, they lose all control from that point forward. And you'll hear clients talk about that when you begin to work directly with people who are experiencing alcohol use disorder. And so what now begins to happen is that when alcohol previously was secondary to their life now becomes really focused on or centered on their continued use, continued presence, continued consumption of alcohol. And then lastly, for Jellinek, the fourth and final phase of his alcoholism is what he called the chronic phase, and you see it characterized here. The person at this point is basically drinking and consuming and intoxicated on pretty much a daily, day-long basis. They're rarely not under the influence. When we look at alcohol dependence, what we recognize is that there are symptoms of alcohol withdrawal, and so at some point you're going to need to maintain a blood alcohol level to not enter into withdrawal. And so it makes a lot of sense from a biologic perspective. And the other thing, too, that he talked about is that at this point in late-stage alcoholism, their tolerance for alcohol drops sharply. And so early on, it takes a lot to experience the effects. Now we'll see people who can get the effects with a lot less amounts of alcohol than previously. And they're so consumed to be under the influence that the person now, if they can't obtain alcohol, they now begin to try to look for substitutes for alcohol in order to maintain their alcohol intoxication. So he describes, and his work is described in a lot of detail on pages 92 through 95. There's a nice chart on page 94, a graphic chart, and you're going to see with some of the supplemental material here that what people call the progression chart, or the Jellinek chart, shows both what he has here, what I call the downside of the progression, and you'll see it reads from left to right, the prodromal phase, down to the crucial phase, to the chronic phase, and it gives you some of the symptoms that occur at the various phases. Treatment folks have added the recovery side, and you're going to see that in this module as well. So be familiar with his work. About 30 years after Jellinek's work was published, George Vaillant published the Natural History of Alcoholism, which was really an update of Jellinek's work, and really looked at kind of extending, ideally either confirming or in some cases expanding and amplifying our understanding of some of the findings that Jellinek originally identified. Vaillant's work was based upon two groups of men who had been studied for about 50 years, i.e. from their adolescence into their 60s. He really picked up some research that was being done from the time they began their adolescence. And it really was kind of a continuation of an approach that looked at substance use or alcoholism across the lifespan or across the life cycle. One of the things that you'll see as you look at the synopsis of his work is that there had previously been a perception that people who had, quote, challenges, i.e. impoverished childhoods, things like that, or people who had pre-existing personality or emotional/psychological problems were more likely to develop alcohol use disorders. His findings were to the contrary, that people who developed alcohol use disorder, or alcohol dependence is the term he used, they were not more likely to have had, quote, an impoverished childhood, nor were they more likely to have pre-existing personality or psychological problems. He also found that from a diagnostic perspective, the diagnostic criteria at the time were the DSM-3, and people who had a diagnosis of alcohol dependence, there was a high correlation or overlap between people who were diagnosed with alcohol dependence and people who were identified on a different classification system, more of a social problem classification system, as problem drinkers with high problem indexes. There was significant overlap between those two groups of people. What's important about that is really it just confirmed that as people continued to drink, they would experience more problems. As their problems continued to increase, it was more indicative of people who would meet the diagnostic criteria to have an alcohol use disorder, or at the time alcohol dependence. He also confirmed some of what Jellinek was talking about, i.e. that things did get worse over time. As people's alcohol history, as their continued alcohol use prevailed over time, then what happened is that they began or continued to experience more and more problems as a result of their continued alcohol use. And as a result of that, overall, increasing problems, greater deterioration or problems across their lifespan. So problems increased and overall their life situation became worse. And he also pointed out that for many individuals, as they moved forward along this progressive path of alcoholism, that ultimately people either died as a result of their alcohol dependence or alcohol use disorder, or people got better. They recovered. They stopped drinking and life got better. And many times today, you'll hear people talk about, quote, hitting bottom, i.e. that when people hit bottom, they are faced with really three choices, and you're going to see this on the updated Jellinek chart. People hit bottom, and at the bottom they either die as a result of their substance use, or they get better, they recover, or they're institutionalized. At some point they could have been locked up in insane asylums and mental institutions. Today you're more likely to be institutionalized by getting placed into the criminal justice system. We're going to jump back to Jellinek's work for a second, because you're going to see at the bottom of page 97 that in addition to talking about the 4 stages of alcoholism or alcohol use disorder, he also said that there was not just one type, or the language he used was species of alcoholic. And so he ultimately identified a number of species of alcoholism, and there's differences between how alcoholism looks in different people. And so these 2 slides highlight those differences. What I think is important here is the recognition that substance use disorders, alcohol use disorders, can and will look different in different people. It does not always look the same. There's not always just one specific indicator or one specific symptom of alcoholism, alcohol use disorder. And so you really have to be familiar with how it can manifest itself in different people. And so you're going to see on this slide the characteristics that are associated with 3 of his forms of alcoholism: alpha, beta, and gamma. And gamma is really what is sort of the more classic alcohol use disorder or alcoholism client. But there's some differences. In this next slide, we'll look at a couple other species that he's identified, what he called delta and epsilon. And so recognize that, you know, when you try to distinguish, there are people, for example, if you look at the description here of what he called epsilon alcoholism, there are people who have alcohol binges. And so they meet the criteria for alcohol use disorder, but they go through periods of abstinence coupled with periods of heavy drinking. Binge drinkers, just because somebody's not drinking on a daily basis doesn't mean they don't meet the criteria for the diagnosis of an alcohol use disorder. It can and will look different in different people. The idea of species is not necessarily something that people will adhere to or support today, but the idea that it looks different in different people is something that I think every clinician is familiar with. So the concept here I think that you want to be familiar with is that alcohol use disorder can and will look different in different people. So if we look at where Jelinek work and Valiant's work and other research has led us to today, a couple things. These next couple of slides talk a little bit about current sort of contemporary thinking about alcohol use disorder. There is recognition that alcohol use disorder is not one and the same. It's not homogeneous, it's heterogeneous. There's a variety of factors that contribute to, there's a variety of symptoms that are indicative of, and so it does not look the same in every person. It's heterogeneous, not homogeneous. There is some recognition that there are some factors that may specify not species but subtypes of alcohol dependence or alcohol use disorder, in part based upon age of onset. Earlier onset correlates with more problems during the course of one's lifetime. Later onset typically correlates with perhaps reduced problems during the course of a lifetime. There's some personality traits that may influence both the initiation and development of alcohol use disorder, and also recognition that that alcohol use disorder is complicated by the presence of psychiatric illness. Or if you don't experience a psychiatric illness, it's less complicated. So presence or absence of psychiatric illness is something that's going to influence how it looks, how it's assessed, how it's treated, things like that. In addition, some of the current thinking is that not every individual experiencing a substance use disorder or alcohol use disorder will meet the criteria for the diagnosis or identification of a separate, quote, antisocial personality disorder. Not everybody who's involved with or experiencing alcohol use disorder is involved with criminal behavior. They may be, but it is not a universal condition. And also, your family history may predispose you, if you have a family history that's positive, that there's a history of alcohol use disorders in your family. It certainly increases the likelihood of you developing an alcohol use disorder, but the presence or the absence of a family history of alcohol use disorder doesn't in and of itself guarantee either the development or your, what I call, immunity from developing an alcohol use disorder. So it's a complicated kind of thing. There also is, and they make reference in the chapter to some of the thinking today about the distinction between what's called primary or secondary alcohol use disorder. Primary alcoholism is the identification or recognition that a person who is experiencing an alcohol use disorder or alcohol dependence, it's the primary issue, it's the primary area of focus, that they are pure and simply, although simply is the wrong term here, experiencing an alcohol use disorder. Secondary alcoholism or secondary reactive alcoholism is the perception that the person is experiencing an alcohol use disorder, but it's being triggered by some either psychiatric illness or some other significant or major psychological problem. And so, for example, if a person is drinking, to go back to an earlier reference, if a person's drinking because he or she is depressed, then and develops an alcohol use disorder, the alcohol use disorder, or AUD, would be secondary to their depression. If you treat the depression, the AUD is going to resolve itself. And so there's some discussion of that today. Again, it's not controversial, but I think there's actually recognition of both. That there's some people who are experiencing primary alcohol or other substance use disorder. There's other people who are experiencing co-occurring disorders, and we have to assess and treat the person based upon what he or she is presenting with. This chapter concludes then with a quick walkthrough some of the evolution or evolving thinking about, quote, criteria for, quote, the diagnosis of alcoholism, alcohol dependence, now called alcohol use disorder. This begins on page 99 of the text, and so some of the earlier thinking was thinking that was contained in a publication from the National Council on Alcoholism, who intended to basically make diagnosing objective versus subjective. The goal was to provide guidelines for use in diagnosing It didn't differ from person to person. It was an attempt to identify one standardized set of criteria. You're going to see that over the years, many of the descriptors or the factors that Jellinek made reference to have been carried over into the diagnostic thinking of today. The other goal was that it would then help us understand not only the condition itself, but identify or outline steps to treatment, and ultimately give clinicians, healthcare providers, the opportunity to evaluate, determine when the diagnosis is appropriate, if it's appropriate to keep it consistent, if it needs to be revised, to make it revised, things like that. The chapter then proceeds to talk about both the DSM-3, DSM-4, and the current DSM-5 criteria. Again, you want to be familiar with the criteria on the top of page 102, the DSM-5 diagnostic criteria. You're going to see another video describing the DSM-5 criteria. So the big picture perspective here is that the American Psychiatric Association is responsible for what I call classifying and ultimately given the responsibility to identify the criteria that are used to diagnose the presence of any psychiatric or mental illness. And that includes substance use disorders. It's an evolving process, and so there's been a series of publications from the original DSM to the current DSM-5. So as you can tell, they've been updated on a fairly regular basis. It's a very significant, large publication, criteria for every mental illness, which really is what I call a cookbook, because the way diagnosticians use it, the way clinicians use it, is that if a person presents with certain symptoms, you begin to categorize the symptoms, you look up at the mental illness that you suspect. If the person meets the diagnostic criteria, you're confirming the presence of an illness. If he or she doesn't meet the criteria, then you do not diagnose the illness. And so the chapter describes some of the evolutions that have occurred between 3, 4, and 5. DSM-3 criteria were really an attempt to both reorganize and rename some major groups of psychiatric illnesses. It was a shift from the previous classification system that was used in the DSM-2. There also, at this point, what was significant is that it recognized for the first time, it put the substance use disorders as a separate major diagnostic criteria. So they were recognized as a unique mental illness or behavioral health disorder in and of themselves. The DSM-4 criteria, as they continued on, the evolution from 3 to 4, was an attempt to come up with a standardized set of criteria that applied to all mood-altering and psychoactive substances. And so at the time, there was abuse and dependence criteria, two separate sets of criteria, and you were looking to diagnose substance abuse specific to their drug of choice, or substance dependence specific to the drug of choice. So diagnosis there was always based upon drug or drugs of choice, and you would diagnose separately. Person was using alcohol and cocaine, they would be diagnosed first for the alcohol use, and they may meet the criteria for alcohol dependence. If they're abusing cocaine, they would also have a separate diagnosis of cocaine abuse. And so but the criteria were the same. It's just the drug of choice was the difference between making the diagnosis. There also then was an attempt to ensure that the DSM-4 criteria were integrated with the ICD-10 classification system. Talked earlier in this chapter about both the World Health Organization and the American Psychiatric Association. And then there was discussion or potential disagreement about whether or not the category of abuse should be maintained. It ultimately stayed in. There was a category of abuse that was retained in the DSM-4 criteria. But what you're going to see is that the DSM-5 criteria have now dropped reference to the diagnosis of substance abuse. We now call it all substance use disorders. And again, you're going to take a look at another PowerPoint on the current DSM-5 criteria. We now have dropped reference to substance abuse, substance dependence. They're now classified as substance use disorder, and there's a spectrum. And so there's a total of 11 symptoms, as you see at the top of page 102. If a person meets 2 or 3 symptoms, they're classified as having mild substance use disorder. If a person meets or is positive for 4 or 5 symptoms, they're classified as having moderate substance use disorder. If the person demonstrates 6 or more symptoms, they're classified as severe substance use disorder. So mild, moderate, severe are the descriptors that are used to distinguish between how many symptoms a person is positive for. The other thing is that in the DSM-4 criteria, DSM-3 criteria, legal problems were considered diagnostic. Legal problems are also on many levels a political discussion, and so the DSM-5 criteria dropped the presence of recurring legal problems as being a diagnostic indicator, but they did add what your clients will report, or what our clients report, which is the person describes a continued recurrent craving to continue to use their substance, even when their use is causing them problems. One of the other items of this module is a further exploration of the DSM-5 criteria. So at this point, since you have not used the DSM-4 criteria, this comparison won't necessarily be particularly helpful. Recognize that from a diagnostic perspective, the biggest difference between DSM-4 and DSM-5 from a substance use disorder perspective is that we no longer distinguish between abuse and dependence. There are not separate abuse criteria and dependence criteria as there used to be. Instead, now we have one broad category called substance use disorders, and the person will be classified, if they have a disorder, as either meeting the mild, moderate, or severe criteria sets. So this will set the baseline for you understanding how to use the DSM-5 criteria moving forward. This completes our review of Chapter 4, and I encourage you to, again, reread the material in the book and continue with the activities in this module.